The chats are not visible as of now. The chats are not visible as of now. Okay. Hello, students. So let's start the topic on ectopic pregnancy. So basically, this will be a clinical scenario-based discussion in which we would be discussing how to manage a case of ectopic pregnancy. So first, let's have a look at this question. There is a 27-year-old female. Hello, good evening to all. Yes. Yeah. So let's have a look at this question. So there is a 27-year-old woman who has come with previous history of pelvic inflammatory disease, and she has come with complaints of abdominal pain. Along with that, there is bleeding per vagina, and along with that, while you take the history, you understand that she has missed the period for more than past 2 months. On examination, you see the patient is drowsy, there is hypotension, tachycardia. Along with that, urine pregnancy test is positive. So what comes to your mind when you see such a scenario? What is the first thing that comes to your mind? Chat. You can type in the comment section. What comes to your mind when you see a woman who is having amenorrhea? Along with that, she is having complaints of bleeding PV as well as pain. So this is a typical triad. This triad, whenever you get at this triad, be it in your clinical practice or for your exams, when you see there is amenorrhea, bleeding PV, and abdominal pain, I want you to always think about an ectopic pregnancy. And in this scenario, the special things to note are there is hypotension and tachycardia for this woman. So most probably she is having bleeding, and this hemoperitoneum is leading to hemodynamic instability. And this is leading to hemodynamic instability in the woman. So how are you going to manage this case? Yes. So this is a case of ruptured ectopic pregnancy. And in this, I want you to at least attempt the answer which can come for this. Is it laparoscopic salpingectomy, or are we going to do a detailed ultrasound so as to rule out an ectopic pregnancy? Or are you going to do a suction evacuation, or is it resuscitation and emergency laparotomy? Who all are going to do an ultrasound to establish that this is an ectopic indeed? So this is very important. Whenever you get a scenario, first thing I want you to see is to try to establish whether it is a ruptured ectopic. If it is a ruptured ectopic, whether the patient is stable or unstable. So whenever such a scenario comes in which a patient is having a ruptured ectopic pregnancy, along with that, you see that she is not stable. In such a condition, do not choose for ultrasound. The first thing is resuscitate the patient. You can see that the patient is having hypotension, there is tachycardia. So the first step would be resuscitation of the patient. Along with that, you are going to do an emergency laparotomy. So here, the correct answer is resuscitation and emergency laparotomy. So let's see how do we approach any case of ectopic pregnancy. The main aim of this session is that by the end of this, you should be able to diagnose and manage any case of ectopic. This is one condition many of the students find it difficult when to go for surgery, when to choose the medical management, and when we are going to go for an expectant management. If at all we are choosing the surgery, what type of surgery? So this is the main aim, that you would be able to diagnose the ectopic and do the further things and manage her appropriately. So as I mentioned, the typical triad is amenorrhea, bleeding, as well as pain abdomen. Whenever you see this, you are going to think of ectopic pregnancy. So in ectopic, in this case, if I ask you, what is the next investigation that you are going to do in this case? So what is the next thing that you would do? So whenever you see this, don't jump for an ultrasound. The first thing would be always urine pregnancy test, as was done even in this scenario. You have to confirm that she is indeed pregnant. So the first thing that you would do is urine pregnancy test. And if suppose the urine pregnancy test is positive, Next thing is, if she is hemodynamically stable, the next thing would be transvaginal sonography. If they ask you what is the next investigation, that is transvaginal sonography. If they ask you what is the gold standard investigation, you have to understand that the transvaginal sonography, the ultrasound itself has many limitations. Many a times you might not be able to say for sure that it is an ectopic. So if I ask you which is the gold standard investigation, which is the gold standard? So the gold standard investigation is laparoscopy. That is laparoscopy. So now you might be wondering why in the previous scenario, I did not go for a transvaginal sonography. In that scenario, it was a suspected ruptured ectopic in which she was hemodynamically unstable. In which she is hemodynamically unstable. In such a condition, we have to act fast. You won't go for a detailed ultrasound. If at all needed, we can go for a fast. What is fast? FAST or FAST is focused ultrasonography in trauma. So you will go for a fast scan in the casualty or the A&E, that is emergency and accident and emergency itself, in case you see that there are no localizing signs. If you still have doubt, you can go for a fast. So in suspected ruptured ectopic, if there are no localizing signs, in that scenario, you might go for a fast. But when she is unstable, when you have to act fast, the next thing in this scenario would be to resuscitate the patient. So coming to the management, always in any case of ectopic, any case of suspected ectopic, try to divide your scenario. Is it a ruptured ectopic or is it an unruptured ectopic? So first, let's discuss about a case of ruptured ectopic. So in ruptured ectopic, as I already told you, the first thing that you're going to do is always resuscitation. It is resuscitation if the patient is unstable. So first thing is resuscitation. What is the management of a ruptured ectopic pregnancy? It is very simple. All of you know that once the tube is ruptured, it is distorted beyond repair. Always the management is going to be salpingectomy. I am going to remove the tubes totally. It is going to be total salpingectomy. So the management here is going to be salpingectomy. Now, the question is, what type of salpingectomy are you going to do? Are you going to perform a laparoscopic salpingectomy or will it be laparotomy and salpingectomy? This depends upon the hemodynamic stability of the patient. So the next thing is you would see if the patient is hemodynamically stable or unstable. So if the patient is unstable, so in this scenario, always the management is laparotomy. You are going to go for laparotomy along with salpingectomy. Suppose at the same time, the patient is not at the same time. In another scenario, the question is giving it is ruptured, but the patient is stable. In that case, why do we have to open up the woman? You can manage her very well using laparoscopy. So in this scenario, you are going to go for a laparoscopy. Along with salpingectomy. So here the management would be laparoscopy along with salpingectomy. Hope that's clear now. So first thing, whenever a case of ectopic is given, first thing that you're going to do is you are going to classify it, whether it is a case of ruptured ectopic. If it is a case of ruptured ectopic, you would see what are the vitals of the woman. Is she stable? Is she having hypotension? Is there tachycardia? If your answer is yes, that is there is hypotension, there is tachycardia, patient is drowsy, the patient is hemodynamically unstable. In that scenario, always go for laparotomy and salpingectomy. If your answer is no, she is totally stable as of now, even if it is a ruptured ectopic, we can very well remove it using laparoscopy. Hope this confusion is clear now. This is how we are going to manage a ruptured ectopic. Now, the next thing is, if the question is giving you an unruptured ectopic. So the scenario is giving you, there is an ultrasound which is showing an ectopic and it is unruptured. You can see that there is an NExT cell mass. Maybe it is up to 3 centimeter. So how are you going to manage it? So in a case of unruptured ectopic, the management options include predominantly there is medical management and there is surgical management. There is medical management and there is surgical management. So how do we differentiate this? Apart from this, there is a third one, that is the expectant management, which I would be telling you finally. So first, let's understand how to basically decide for which patient you are going to give a medical management and for whom you are going to give a surgical management. So medical management is given in all scenarios. You understand that the patient has to be stable. As I already told you, if the patient is unstable, I'm not going to waste time just by giving her medicines. I'm going to do a surgery and remove the tubes. So the first thing is clinically, she should be stable. She should be stable clinically. Along with that, the pain should be mild or nil. That is, she should not have significant pain. No significant pain. If in case your question is giving you that the patient is having severe pain, she is having significant pain, high chance that she is going to rupture soon. In that scenario, you won't opt for a medical management. So first thing, she should be stable. The pain should not be significant. All right. What about beta HCG? So in the question, they will give you beta HCG levels. And this beta HCG level has to be less than 5,000. This has to be less than 5,000. And there should not be any fetal cardiac activity. Once there is heartbeat in the fetus, very less chance that the medicines are going to work. So beta HCG should be less than 5,000 and there should not be any fetal cardiac activity. Very, very important points. And the size of the sac or the size of the pregnancy should be less than 4 centimeters. It should be less than 4 centimeters. All these criteria has to be fulfilled together so as to give a medical management. It should not be just one criteria which is fulfilled among these. All these 4 criteria should be fulfilled together so as to give a medical management. So now you can understand when are you going to give a surgical management. Just you have to remember one among these. The second will automatically come to you. So it's very easy. So just the opposite. That is, the patient is unstable, the beta HCG is more than 5,000, there is presence of fetal cardiac activity, and the size is more than 4 centimeters. If any of this is fulfilled, I am going to choose surgical management. For medical, all these have to be fulfilled together. Whereas if any of them are not fulfilled, I will jump to surgical management. So this is basically roughly how you can divide it as medical or surgical management. But that is not it. There are some more things. So first, I want you to tell me what is the medical management that we are going to commonly give, or what is the medical management that you have seen for an ectopic pregnancy? Yes, it is methotrexate. So we commonly give methotrexate. So you have to understand, or you have to ensure that the patient is not having any contraindications for methotrexate. So that is a prerequisite. There should not be any contraindications for methotrexate. So what are the contraindications for methotrexate? So first is the patient should be suitable for giving medical management. That means the patient should not be having a ruptured ectopic. So ruptured ectopic is a contraindication. Next, there should not be any intrauterine pregnancy along with it. We have to ensure that there is no intrauterine pregnancy. The patient should not be breastfeeding. If the patient is breastfeeding, this methotrexate will get excreted through the breast milk to the fetus as well, to the baby as well. So ensure that the person is not breastfeeding. And you might have already learned in pharmacology, there are so many side effects that is associated with methotrexate. There can be problems in the liver, in the lungs, in the bone marrow, and so many side effects, even in the kidneys. So usually what I do is, before starting the patient on methotrexate, I send all the blood investigations. I take a detailed history of the woman. I send all the blood investigation to ensure that her complete blood count, her LFT, RFT, everything is normal. Why is it so? Because all these, if at all any abnormalities are there, it is a contraindication. So understand that if the patient is having any lung disease, that is any active pulmonary disease, any history of hepatic or renal dysfunction, that's why I'm sending the LFT, RFT and checking for that. Any history of derangement in the complete blood count, that is if the patient is having severe anemia, or the platelets are less, that is there is thrombocytopenia, the counts are less, there is leukopenia, all these are contraindications. Apart from this, the methotrexate can predispose the woman to ulcers. There can be mucositis and even ulcers. So if the patient is having active peptic ulcer disease, again, that is a contraindication. If the patient is having immunodeficiency, so this is going to suppress, the methotrexate is going to suppress the bone marrow. So if the patient is already having immunodeficiency, I'm not going to give the patient methotrexate. If the patient is having any hypersensitivity to the drugs, again, I'm not going to give her methotrexate. You can just remember that any hypersensitivity, of course, you won't choose the drug. And apart from this, compliance to the drug is very important. Why is it so? So after giving the drug, I'm not just going to leave the patient. I'm going to follow up this patient. I'm going to regularly monitor her and follow her up. So my question is, how are you going to follow up these patients after giving her a medical management? So let's see how you are going to give this methotrexate and how you are going to follow up these patients. So as you know, this is methotrexate that we give, and the commonly used regimen is single dose regimen. So in this, what I'm going to do is I'm going to give the methotrexate, and the day in which I give the methotrexate is day 1. This is day 1. So I have given the methotrexate here. This is methotrexate, which I have given. All right. So I would be checking the beta HCG on this day, that is day 1. And then when is the beta HCG repeated? I would do the beta HCG on day 4. I would do the beta HCG on day 4 and day 7 as well. So all of you know that after giving methotrexate, there has to be some fall in the level of beta HCG. So the questions are, between which days are you going to compare the levels? Is it between day 1 and day 4? Is it between day 4 and day 7, or day 1 and day 7? Yes. So you are going to measure it between day 4 to day 7. So you will measure the levels between day 4 to day 7, and there should be fall of at least 15%. There should be a fall of 15%. So this is the fall that you expect. If this is going fine, then if there is a fall of 15%, I will follow up the patient weekly. I will follow up the patient weekly till the beta HCG is negative. Till the beta HCG is negative. Suppose you don't get this much fall. If you don't get this 15% fall, you can give her one more dose of methotrexate. So again, I'm going to repeat the dose of methotrexate. I would give her the second dose of methotrexate here. And again, I will take this day as day 1. And again, repeat the beta HCG on day 4, day 7, and compare between them. So whenever I'm giving the methotrexate, I will take it as day 1. So first cycle, I had given it. Then I saw that the fall is not 15%. Then what I will do, I can again repeat the patient another dose of methotrexate. And that day would be considered as day 1. And again, I would check the beta HCG on day 4 and day 7. So I had given her methotrexate twice. Suppose after giving twice the methotrexate, the patient has not responded. Even now, the fall is less than 15%. So this is a case of failed medical management. So I will label her as failed medical management. Are you clear? So this will be labeled as failed medical management. So we have the medical option. The medical option has failed. So what would be the management for her? It is going to be surgical management. So we understand that we are repeating beta HCG so many times for her. So compliance of the woman is very important. If the question is giving you the woman is not compliant, so you can't give her medical management. You will have to think about surgical management. The question is giving you that the patient has already received 2 doses of methotrexate and it is not working. So it is failed medical management. You are going to go for surgical management. The question is giving you that the size of the sac is more than, the gestational sac is more than 4 centimeter, or there is presence of fetal cardiac activity, or beta HCG levels are high. It is above 5,000. Think about surgical management. All right. So these are the 2 things that we have seen. That is the medical and surgical. So I told you about surgical management. So what are the types of surgeries that are available? So basically the most common, so I'll just write the indications for you here once again. So as we discussed, if the patient is hemodynamically unstable, if she is unstable, size is more than 4 centimeter, beta HCG is more than 5,000, there is presence of fetal cardiac activity, patient is non-compliant, or if they are giving you the medical management has failed. Okay, so these are the indications that we already discussed. All right, so as we are discussing, now let's see what are the types of surgeries that are available. As you all know, the most common one that is done is the salpingectomy. Salpingectomy basically means I'm going to remove the tubes. That is salpingectomy. So apart from this, there are some tubal conservation surgeries. That means I'm going to preserve the tube. I'm going to do something so as to remove the products, and I will repair the tube and preserve the tube. These are tubal conservation surgeries. This includes salpingotomy, which is not commonly done now. One is salpingotomy and other is salpingostomy. Salpingotomy and salpingostomy. What is the difference between them? So in salpingostomy, so suppose this is the tube that is there, and we have an ectopic pregnancy here. So in this, I'm going to give an incision in the anti-mesenteric border. What is meant by anti-mesenteric? So we have the tube here and we have the mesosalpinx, which is hanging down. So I'm going to give an incision on the opposite side. That is, I would give an incision here. This is the anti-mesenteric border. I would give an incision, remove the products and leave it open. I'm not going to suture it. Within few days, it is going to close on its own. If I'm going to give an incision, remove the products and leave it open, that is ostia, salpingostomy. This is the one which is more common than salpingotomy. So in salpingotomy, I'm going to again give an incision, remove the products, and I am going to repair it back. I would suture that part. So this is the basic difference. Let me again repeat it for you. We have basically tubal removal surgery, that is salpingectomy, in which I'm going to remove the complete tube. Or we have tubal conservation surgeries. This includes salpingostomy and salpingotomy. So in salpingostomy, I'm just going to give an incision that would be in the anti-mesenteric border. I would remove the products and then I'm going to leave this opening open. I'm not going to close it. Whereas in salpingotomy, I'm going to give an incision, remove the products, and I'm going to repair it or suture it back. This is the difference between these two. So salpingectomy is the commonly done one. Salpingostomy or otomy, both of these have high chance that there can be recurrence of ectopic. There can be failure. So even in this scenario, if you're going for this procedure, you are going to follow up the patient. You will follow up the patient with beta HCG. If you see that the treatment has failed, the beta HCG is rising, then again you will have to go in and go for surgery. So if she has undergone salpingectomy, there is no need for follow-up. You are not going to follow up her with beta HCG. There is no follow-up. But if you're going for a salpingostomy, you are going to follow her up with beta HCG. So a common indication in which we do the salpingostomy is for a patient in whom the contralateral tube is damaged. So let me repeat it for you. So you get a patient who desires pregnancy. First of all, she desires pregnancy. She wants to get pregnant, and she says that previously also she had an ectopic maybe or some pathology of the other tube. So the other tube is gone now. She already had some surgery or some problems with the other tube. Now she just has one tube and the ectopic is in that tube and she has not ruptured, of course. So in that scenario, you can go for salpingostomy. So one main indication is if contralateral tube is damaged. If the contralateral tube is damaged, along with that, as you all know, she should desire fertility. She desires fertility and it is not ruptured. It is not ruptured. Once it is ruptured, as I told you in the beginning itself, there is only salpingectomy. I hope you remember the first algorithm which I taught you. First, you divide this ruptured, unruptured. If it is ruptured, always salpingectomy. There is no role of salpingostomy or otomy in that scenario. Always salpingectomy. And next thing is hemodynamically stable, unstable. If she is unstable, resuscitate, laparotomy, and salpingectomy. If she is stable, laparoscopy and salpingectomy. Hope that's clear now. All right. So this is about the surgeries. So as we mentioned, I'm just summing up those points here for you. The first step that I'm going to do in a ruptured ectopic is resuscitate. Resuscitate the patient. If she is stable, I'm going to go for laparoscopic salpingectomy. If she is unstable, it would be laparotomy and salpingectomy. Laparotomy and salpingectomy. All right. So I left something in between, right? What about this expectant management? So I kept it to the last because I don't want you to always think about expectant first. Mostly the questions which they give you is to choose for a medical or surgical. But there are some scenarios in which expectant management can come in. So sometimes what happens is that at times the fate of ectopic can be, it can abort on its own. The ectopic can abort on its own sometimes. Sometimes the vascular supply to the ectopic is not sufficient and it dies there itself and it gets aborted on its own. So in few scenarios, we can go for an expectant management. What is expectant management? Expectant means basically we are not doing anything. I'm just going to expect or I'm going to wait and see that maybe the ectopic will resolve on its own. So you understand that I'm not going to try it for all the cases. It is reserved for very few cases alone. So this includes, if you just think, the ectopic has to be very small, the beta HCG has to be small, the patient should be stable, she should not have any pain, she should be a completely normal patient, right? So clinically, she has to be stable. There should not be any pain. The size of the ectopic should be small. The size of the ectopic should be small. Typically, always it has to be less than 4 centimeters. The size should be small. The HCG levels has to be less than 1000. This is less than 1000. The size has to be less than 1000. And the success rate is much more if the levels are less than 200. If the levels are less than 1000, you can see failure up to 25% of the cases. The chance of success is very high if the beta HCG is less than 200. So This is as per the RCOG guidelines. If the size is small, less than 4 centimeter, and the beta HCG levels are low, the beta HCG levels are low. What I mean is it is less than 1000. But if the levels are less than 200, the chance of success is much higher. So, and the patient should be able to come for follow-up as well, because I am going to repeat the beta HCG. And on follow-up, the beta HCG should be in falling trend. It should be in falling trend. The beta HCG should be in falling trend. Very important. Once you did the beta HCG, you saw that it was 500. Next time you did this, saw that it was 600. It's rising. In that case, I'm not going to wait and do an expectant management. The beta HCG should be in falling trend. Most of the scenarios which they give you comes mostly from the ruptured ectopic, as well as scenarios in which you go for medical or surgical management. Hope it is clear how you can categorize these patients and divide them either into medical, surgical, or as per a ruptured ectopic. All right. Now, finally, discussing a small bit again. After this, I would be taking all your questions and queries as well. So, final bit. What is meant by a heterotopic pregnancy? What is a heterotopic pregnancy? Hetero means different, right? So, heterotopic pregnancy is basically you have an intrauterine pregnancy. Along with that, there is an ectopic pregnancy as well. So inside the uterus, you have one pregnancy here, which is an intrauterine. Along with that, you have an ectopic along with it. So intrauterine along with ectopic pregnancy is known as heterotopic pregnancy. So in this scenario, what would be your management? What are you going to do? So options again, are you going to choose a medical management? Are you going to go for a surgical management? Can you comment here? So what are you going to choose in this scenario? Yes, waiting for your comments. I can't see any answers. So the important thing here is you have to understand that the patient is having an intrauterine pregnancy. So what was the first contraindication that I told you for medical management? There should not be a live intrauterine pregnancy. So again, this is a previous year question. If they give you heterotopic pregnancy, always go for surgical management. What are you going to do? In this scenario, you can't give her methotrexate. You are going to remove this tube, remove the ectopic, save this pregnancy, let this pregnancy go on. So you are just going to go in and remove this tube. So it is always surgical management. So the management is always surgical. Never choose medical management for a case of heterotopic pregnancy. Let me quickly summarize what we have learned till now. The classical triad of ectopic pregnancy is when a patient is having amenorrhea, bleeding, and pain. The first thing that you think of is ectopic. Always keep high suspicion for ectopic. Why? Because this is a life-threatening condition. You have to act. So what is the next thing that you're going to do? Do a urine pregnancy test, confirm that she is indeed pregnant. The next investigation would be a transvaginal sonography. Suppose the question is giving you the patient is unstable, the patient is hemodynamically unstable, and there are localizing signs such as she's having pain, there is tenderness. In such a situation, always you can go for resuscitation and laparotomy if she's unstable. So again, any scenario, you will divide her as, you will think, is it ruptured? Is it unruptured? If it is ruptured, management always salpingectomy. And this depends upon whether the patient is unstable or stable. If she is unstable, go for laparotomy and salpingectomy. If she is stable, laparoscopy and salpingectomy. Next scenario, she is an unruptured ectopic. Now you have options with you. You have the option of expectant management, medical management, and surgical management. So medical and surgical are the most commonly asked one. You should know them thoroughly. The medical management is basically methotrexate. And this methotrexate is given as a single dose regimen, and this is given to patient in whom she is stable, no significant pain, size is less than 4 centimeter, beta HCG is less than 5,000, there is absence of fetal cardiac activity. Any of this is not fulfilled, you are going to go for surgical management. Methotrexate, one more thing, the other medical management includes drugs such as actinomycin D, even mifepristone can be used. These are some of the drugs that can be used in the, even prostaglandin injections can be used, but these are not commonly practiced, and the most commonly used one is methotrexate. I am going to give this medicine on day 1, and the dose in which I would give is 1 milligram per kg. That is, if she is 50 kg, I'm going to give her 50 milligram intramuscular. After giving that, I'm going to repeat on day 4, day 7. Between day 4 and day 7, the fall should be 15% fall has to be seen. If the fall is not there, I would repeat the dose of methotrexate again one more time if she is compliant. If that is failing, next management is surgical. Surgical management, the options include either salpingectomy or tubal conservation surgeries. In tubal conservation surgery, the common one is salpingostomy. That is, I cut the tube, remove the products, leave the tube open. That is basically salpingostomy. I will go for tubal conservation only if she desires fertility, she is stable. Along with that, I see that the tube can be salvaged. Along with that, the contralateral tube is damaged. In that condition, I'm going to try to save this. If I go for tubal conservation, I'm going to follow her up with beta HCG levels. Hope this topic is clear now, and we will be able to attempt and answer any question, clinical question that comes regarding management of ectopic pregnancy. It's a very important topic as well. So now let's take the questions and queries. Any doubts? Any doubts? So we'll call it a day if everyone is clear regarding the management of ectopic. Ectopic is a very important topic. You should be able to answer any clinical scenarios that come from this, especially if the next pattern of question comes, they can give you clinical scenarios, because this is one scenario which we commonly encounter and manage, and each and every one of you should know what is the right management in case of ectopic. Yes, of course, the video would be posted in detail. Yeah, the notes would be coming soon. Basically, mostly this would be coming within after a month's time. So, yes, the whole session would be posted. It would be available in YouTube. You can watch that. Would definitely be available. So the beta HCG measurements. Beta HCG measurement, you mean when the beta HCG should be done? Yes, as we mentioned, the beta HCG has to be done on day 4 and day 7. I am going to do the beta HCG on day 1, day 4, day 7. And I am going to see the fall between day 4 and day 7. And the optimal fall is at least a fall of 15%. If the question is giving you the fall is less than 15%, if the fall is not 15%, then the management is not working. You are going to repeat the dose of beta. We are going to repeat the methotrexate. So, yes, the critical titer of beta HCG levels. So, I think what you mean is not critical titer, that is the discriminatory zone. Am I right? That's what you meant. What you meant is discriminatory zone of beta HCG. Yes, most likely he meant that. So, the discriminatory zone of beta HCG is that level at which you have to see an intrauterine pregnancy. So this is that level at which you are expecting to see a pregnancy. So the cutoff is in case of transvaginal sonography. As per NOVAC, it is 1000 to 2000, but mostly it is taken as 1500. The beta HCG discriminatory level is 1500, and trans-abdominal sonography, it is 6000. So suppose a patient is having amenorrhea, she is having UPT positive, and now you have done the beta HCG. So now you have done a scan to see for what type of pregnancy it is. So you have a patient who's having amenorrhea, UPT is positive, so definitely she's pregnant. Now you have done a scan. So at this level, you can't see whether it is intrauterine or ectopic. So at that point of time, if you did a beta HCG level, and the beta HCG level shows that the level is more than 1500. What it means, this is the discriminatory zone. If it was an intrauterine pregnancy, at this level, I should have seen the pregnancy. I'm not seeing it present. So there is high chance that it is maybe an ectopic pregnancy. This is the importance of it. So along with it, let me tell you a small topic along with it I can teach you, that is about pregnancy of unknown location. So I'm going to label this patient as pregnancy of unknown location. What does this mean? I cannot understand where the location of the pregnancy is. What is the location of pregnancy? So if there is a patient of amenorrhea who's pregnant, I did a scan, I'm not unable to find where the pregnancy is, I will label her as pregnancy of unknown location. Previous year question, how are you going to follow up this patient? How are you going to follow up this patient? So my first question would be, what are the differentials in this case? So the differentials here include either this could be a very early pregnancy, which I'm not seeing. So this could be a very early intrauterine pregnancy. Or the second possibility is it could be an ectopic pregnancy, right? It could be an ectopic pregnancy. Or this could be an early miscarriage or abortion. That means the patient has already miscarried. That is why I'm not seeing any intrauterine pregnancy. These are the three possibilities that can be there. So what am I going to do? That was the question. So you have a pregnancy of unknown location. How are you going to follow up? What am I going to do? I would do a beta HCG level. So we are going to do a beta HCG level. So in case of an intrauterine pregnancy, what is there? The placenta is well established, and the placenta will secrete the beta HCG hormone. And you will see that there is doubling of beta HCG. So I am going to do the beta HCG now, and I will repeat the beta HCG after 48 hours. I'll repeat the beta HCG after 48 hours. If there is doubling, mostly it is an intrauterine pregnancy. And once the level is more than 1500, I should see that there is an intrauterine. If I don't see, I will have a high suspicion for an ectopic pregnancy. If there is fall in beta HCG, there is fall in beta HCG. So I did it first, and after 48 hours, I have repeated, and I see that there is a fall of 50%. Mostly it is miscarriage. Mostly there is an abortion that is going on. So I'm going to follow her up like that. Suppose the levels are in between this. There is no doubling, and the values are not doubling as is. There is some increase, but it is not doubling. Or it is falling, but the fall is not up till 50%. Anything in between, I will think about ectopic pregnancy. In between, I'll think about ectopic pregnancy. And if the discriminatory zone is more than the levels which I told, and if the beta HCG is more than the discriminatory zone, if the beta HCG levels are more than the discriminatory zone, if beta HCG is more than the levels of discriminatory zone, that is 1500 in case of TVS, there should be high suspicion of an ectopic. If you can't see an intrauterine pregnancy at this level, keep a high suspicion for an ectopic pregnancy. This is basically about pregnancy of unknown location. So is that doubt clear? Is it clear now? Okay. Okay, so let me, yeah. Yes, discriminatory. So the ideal word should not, I see that you are using the word critical titer. I think you are confusing with the chapter of RH isoimmunization. In RH isoimmunization, we use the term ICT critical titer. But for beta HCG, the ideal term is the discriminatory zone rather than critical titer. Maybe you got the term critical titer from the topic of RH isoimmunization. There we have the ICT titer, which has the critical titer. Here we have beta HCG, which is basically the discriminatory zone. Okay, thank you, Himanshu, that you have understood that. That's good. And yeah, Rajni, I see a doubt that whether it is 2000. The best answer would be 1500. The best answer is 1500 as for transvaginal sonography. What is given in NOVAC is 1000 to 2000, but majority of the sources are going with 1500. So go with 1500. For transvaginal sonography, please note that 1500 is for TVS or transvaginal sonography. Why is beta HCG done? Okay, so I think you mean why in the follow-up, why for pregnancy of unknown location we do beta HCG, right? That's the question. So basically, if you have a pregnancy, as I told you, the options are, it could be an ectopic pregnancy, it could be an intrauterine pregnancy. So it could be an ectopic, it could be an intrauterine pregnancy. If it is an intrauterine pregnancy, the placenta is going to be well established. And what is the hormone that is going to be secreted by this well-established placenta? What is the hormone that is going to be secreted from here? So this is going to be beta HCG, right? And if it is an intrauterine pregnancy, this beta HCG is going to increase. It will increase rapidly. There's going to be doubling. But at the same time, suppose it is an ectopic. There is poorly developed placenta. This poorly developed placenta is going to secrete less beta HCG. It would be beta HCG is going to be less. There won't be any doubling. The second scenario, which we saw, there won't be doubling. Finally, if it is an abortion that is happening, if it is an abortion, already the pregnancy is failing and the beta HCG is going to fall. The beta HCG is going to fall, and ideally the fall, if it is up till 50% fall, would be observed. Anything that is happening in between this range, that is, there is no doubling, there is some fall, but it is less than 50, I will think about ectopic. I would do the beta HCG and again follow her up, do the scan along with it, and try to confirm whether it is an ectopic pregnancy. So let's see the other questions. Okay, thank you. Manish, am I clear now? The beta HCG measurement question? I hope that's clear. Yeah, regarding Dawn's question on whether there would be doubling of beta HCG, will be slow doubling or a falling trend, whether there is slow doubling or falling trend. So it is something in between that is happening. That's what I told you. There won't be doubling as such. So in the question, in any scenario, you should not see doubling as such. So it could be less than doubling, or there could be some amount of fall as well, but the fall should never be up till 50%. Something in between, you will think about ectopic pregnancy. If the fall is up till 50%, you will think about abortion. If there is doubling, it is most likely ectopic. It's most likely intrauterine. In between, think about ectopic pregnancy. Hope that's clear now after this explanation. So, any other questions? You can feel free to ask me any questions. So Manish has asked regarding beta HCG in molar pregnancy. So let's briefly, I'll tell you about the molar pregnancy. So if they ask you, what is the treatment of choice in case of molar pregnancy? What is the treatment of choice in molar pregnancy? Any answer? It is going to be, yes. What is the treatment in case of molar pregnancy? Okay. So this is going to be suction evacuation. So the treatment of choice is suction evacuation. I'm going to do suction evacuation and remove the products. So after this, we are going to follow up this patient with beta HCG. I'm going to do beta HCG weekly till it is negative. Once, even if it is negative, I will again follow up her up. monthly beta HCG up till 6 months. This is the basic management that you should know. I'm going to go for a suction evacuation. I would do weekly beta HCG till it is negative. And again, I'm going to go for monthly beta HCG at least till 6 months. Now, just an additional question for you. So in case of molar pregnancy, till 6 months, she should not get pregnant. So what is the contraception that you're going to give this at this time? What is the contraception that you will give a patient who is under follow-up for a molar pregnancy? It is going to be pills. Oral contraceptive pills are the contraceptive of choice. Very important question. So the treatment of choice is suction evacuation. You are going to follow her up with beta HCG, no pregnancy up till 6 months. And in that meantime, you are going to give her COCs or combined oral contraceptive pills. All right, so we'll call it a day now. No more questions, right? Yeah, Geetika, you're right. Excellent answer. It is COCs, yes. I'll wait for 2 minutes for any more questions, then we'll call it a day. Okay. Okay. Thank you. Then hope you all understood the topic of ectopic very well and you'll be able to answer all questions that's coming from this topic. Thank you.